Assalamu alaikum. So, in the last lecture, we studied about calcium and phosphatine regulation, that is via parathyroid hormone, calcitonin, and vitamin D. Now, we're going to discuss some things about calcium's metabolism. This is going to be a smaller lecture because we'll just finish calcium metabolism and the disorders which are associated with it. So, this one is going to be a small one, and maybe in the evening we can discuss the questions that I've given you, or maybe tomorrow. I'll just let you know in the group, okay, a few hours before we commence that, or you can post your questions and I can answer to that kind of thing. So let's start about the calcium and its metabolism. So the body of a young adult human being contains about 1100 grams or 27.5 moles of millimoles of calcium, and 99% of the calcium is located in the skeleton, that is the bones. The remaining calcium is found in plasma, which is normally about 9 to 11 milligram per deciliter. Now the calcium is measured in different units. It is measured in milligram. It can be measured in milliequivalent as well as in millimoles. So it depends on the region where you are practicing. So the major component, the major part where the calcium is located within our body is the bone. The calcium in the bone is of two types. The first is the calcium which is available as a readily exchangeable reservoir that can be readily exchanged, absorbed, or excreted in or out of the bone. The other component, which is in much larger proportion, is a pool of stable calcium that is only slowly exchangeable, and this is in a form of molecule that is embedded within the bony matrix. So the other major place where the calcium is the plasma. Of the calcium, total calcium is in the plasma, that is about how much? 1% of the body. 41% of the calcium is attached to proteins, and another 9% is associated with anions such as phosphate and citrate. So it is found in the form of calcium phosphate, calcium citrate, bisphosphate, etc. The remaining 50% calcium is ionized and it circulates the blood in its free form, that is the Ca++ calcium 2 plus ion. The free ionized and bound forms of the calcium are in equilibrium. So there is 50% ionized, 50% bound, and they are in equilibrium to each other. They equalize each other kind of. The free calcium is the physiologically active and precisely regulated form of the calcium. So this is the main calcium which would be responsible for many of the body processes, and this is the calcium whose level, if decreased or increased, would activate the parathyroid hormone calcitonin system. The ratio of free to bound calcium is dependent on pH of the body. It would decrease in alkalosis and increase in acidosis. So as soon as pH starts increasing, calcium would start decreasing, and as soon as pH starts decreasing, calcium would start increasing. So protein bound calcium plus phosphate and free citrate bound calcium equalize the so protein bound calcium plus phosphate and citrate bound calcium would be in complete harmony with the free calcium. So now let's look at how the calcium metabolism would take place. So our daily intake of calcium is approximately 300 milligrams per day. This calcium is being absorbed from the gastrointestinal tract and being transported to the blood, from where it is transported to the intercellular fluid. The blood, everything is part of the extracellular fluid, so it is transported from the gastrointestinal tract into the extracellular fluid. From the extracellular fluid, this calcium may be transported to the cells where it is deposited, or may be deposited into the bones. About 500 milligram calcium per day is absorbed within the bones. The total calcium that is present in the bones makes up about 10 lakh milligram or 100,000 milligram of calcium. So 500 milligram calcium is deposited in the bones, and 500 milligram calcium is reabsorbed from the bone into the extracellular fluid. Moreover, the kidneys are filtering about 9980 milligram calcium per day and reabsorbing 9880 milligrams of that calcium back in the blood. So only 100 milligram calcium is excreted per day via kidneys, whereas about 900 milligram calcium is excreted via feces per day. So this is how the whole chain of calcium works in our body. So what are the functions of calcium in our body? It is a vital second messenger, acts in carrying impulses, it is attached to different receptors of different enzymes, where it acts as a second messenger. Moreover, it has a role in blood coagulation. It is a coagulative factor. I think factor 4 has close association with calcium. Moreover, it has a very active role in muscle contraction. Calcium channels are very important for muscle contraction. It serves a function in nerve conduction as well as in secretions from the glands. Now let's look at the calcium regulation. So we've discussed all of this already. Now we're going to just review it. So thyroid gland releases calcitonin. This calcitonin increases absorption of calcium into the bone, decreases calcium uptake in the intestines, and decreases calcium reabsorption in the urine, resulting in decreased level of calcium in the extracellular fluid in the serum. So if calcium level is too high, this calcitonin is secreted from the thyroid gland. So all of these effects of calcitonin would result in decreased level of calcium. Calcium level would fall in the plasma, and this would equalize the effect due to which the calcitonin was being released. So calcium was increased, calcitonin was released, it decreased calcium, now the calcium is at normal level again. Now what happens if the calcium level gets too low? It would have an effect on the parathyroid gland, where parathyroid hormone would be secreted. This would cause increased resorption of the bone and release of calcium from the bone, increased calcium reabsorption from the kidneys as well as the intestines, which would result in increased calcium level. And this would harmonize, this this would uh, harmonize the normal calcium level in the blood. So this is how the homeostasis of calcium works. Moreover, the vitamin D is activated in the kidneys via parathyroid hormones, which would go on in small intestine and increase calcium uptake. So this is the whole story of the calcium regulation. Now let's look at applied physiology of calcium, of parathyroid gland, etc. Okay, so let's talk about some problems that may arise due to increased or decreased hormones which regulate the calcium. So the condition that we're going to study is known as hypoparathyroidism, that is decreased secretion of the parathormone or the parathyroid hormone from the parathyroid gland. So if there is decreased function of the parathyroid gland, it would lead to decreased level of parathyroid hormone. The different causes of hypoparathyroidism can be the surgical removal of parathyroid gland, because the parathyroid gland is located on the thyroid and it is very small. So sometimes during surgery of goiter or of some other pathology of the thyroid gland, during thyroidectomy or the procedure in which the thyroid gland is being removed, the parathyroid gland is removed accidentally. Due to removal of parathyroid glands, this hypoparathyroidism occurs. Other causes can be autoimmune destruction. Sometimes the body generate some autoimmune reaction against the parathyroid gland, that is the cells of the body which would normally destroy the bacteria and the foreign structures would identify parathyroid gland as a foreign structure and start destroying our own parathyroid gland. In that case, hypoparathyroidism can occur. Then there is a congenital condition that is known as Dye-George syndrome, in which there is congenital absence of parathyroid gland. Plus there can be pseudo-hypoparathyroidism, that is a rare familial disorder characterized by target tissue resistance to parathyroid hormone. So the parathyroid hormone being released from the parathyroid gland would be normal in concentration. If we check the parathyroid hormone concentration in the blood of that person, its result would be normal. But the problem is in the receptors of the parathyroid hormone, which are present on the proximal convoluted tubule in the kidney, in the bones, and in the intestine. Parathyroid hormone would be normal, it would be produced normally, but it would not be able to act on the target organs because of some kind of abnormality or absence of those receptors, or due to tissue resistance to parathyroid hormone. If there is hypoparathyroidism, it would cause hypocalcemia, that is decreased calcium level in the body, and it may also cause tetany. Now what is tetany? We'll just discuss in the next slide. So tetany is a clinical condition which is characterized by hyperexcitability of nerves and muscles due to absolute or relative hypocalcemia. So the patient would start convulsing uncontrollably if the calcium level gets low. पेशेंट को दौरे पड़ना शुरू होते हैं, ठीक है, convulsing rapidly. This is the same thing that can happen in tetanus infection. In tetanus, there is a toxin that is produced by Clostridium tetani. That toxin is producing hyperexcitability of nerves, whereas in hypocalcemic tetany, the same hyperexcitability of nerves is occurring due to decreased serum calcium level. So hypocalcemia, which can be due to hypoparathyroidism or vitamin D deficiency or malabsorption in the intestine or chronic kidney disease or acute pancreatitis, all of these causes would lead to hypocalcemia, that is decreased calcium level, which may lead to tetany. Or tetany may also occur due to alkalosis. Due to repeated vomiting, sodium ions are lost outside the via the gastrointestinal tract, via vomitus, or excessive oral alkalis if we keep on taking, or hyperventilation, breathing more with more pace and more respiratory rate. If the patient is breathing, more carbon dioxide would be pushed outside from the lungs and the body would undergo alkalosis, respiratory alkalosis. This alkalosis or increased pH would cause decreased calcium level, and that would in turn result in tetany. So what happens in tetany is, due to low calcium level, which may be due to any cause, due to hypoparathyroidism, due to alkalosis, all of the causes which we've just seen, there is increased permeability of sodium channels in neuronal membrane, which causes increased depolarization of the tissues. Tissues are easier to depolarize, and action potential can be spontaneously generated again and again. The resting membrane potential is basically affected, and action potential can be generated with smaller impulses. This action potential, when generated, causes normal contraction of the muscles, but if it is being generated again and again at a rapid pace, it would cause uncontrolled spasm of the muscle, uncontrolled contractions of the peripheral muscles in a speed. So muscular spasms would occur, that is known as tetany. So how would it look? How would the patient look? What are the signs and symptoms? There would be carpopedal spasms. This is a peculiar attitude of hand due to muscular spasm, where there is flexion of elbow. The elbow is turned towards the body, and wrist joint. Wrist joint is also flexed, as you can see in this picture. There is adduction of thumb. Thumb is adducted, and extension of fingers. Fingers are extended. So this is carpopedal spasm, which is a sign of tetany. Okay, there may be laryngeal stridor, that is loud crowing sounds during inspiration. When the patient inspires air, there is a peculiar sound that is produced by the larynx due to spasm of the laryngeal muscles. This condition, laryngeal stridor, may prove to be fatal, because if the patient is unable to inhale air due to laryngeal spasm, the patient may undergo hypoxemia of the brain, permanent brain damage, and may die within seconds or minutes. Other clinical features include anxiety, muscle cramps, convulsions, arrhythmia of heart, that is disturbed rhythm, heart failure, etc. Moreover, latent tetany. Latent tetany is a tetany where all the clinical signs are not being exhibited yet, because it has not progressed to a severe stage. This kind of tetany that shows decreased serum calcium level but not to a severe extent would show Trousers sign and Chvostek's sign. Trousers sign is carpopedal spasm that would be developed after 3 minutes of arresting blood flow to the hand. So if we tie a thing around the arm of the person, it could be anything, a string like structure, or we just need to stop the circulation, decrease the circulation of the arm to some extent. So after 3 minutes the patient would develop carpopedal spasm, the same sign which was being shown here, that is flexion of the elbow, flexion of the wrist, and adduction of thumb and extension of fingers, or tapping the facial nerve on the side of the face would cause twitching of same side of facial muscles. So this was tetany. Now let's discuss hyperparathyroidism. Hyperparathyroidism is a condition in which there is increased secretion of parathyroid hormone, which would cause increased secretion of parathyroid hormone, which would cause increased level of calcium in the blood. So increased function of parathyroid leading to increased level of parathyroid hormone is known as hyperparathyroidism. It would cause hypercalcemia, increased calcium in blood. There are many types of hyperparathyroidism, but we'll discuss primary and secondary hyperparathyroidism. Primary hyperparathyroidism is when the problem is in the parathyroid gland. So primary hyperparathyroidism is when there is problem in the parathyroid gland. This would cause increased secretion of parathyroid hormone from the parathyroid gland, which is usually due to a tumor of the parathyroid or ectopic parathyroid tissue, that is tissues which have the same function and structure as that of the parathyroid gland but are present in some other structure. This is true in case of lung carcinomas. In lung carcinomas, there is parathyroid tissues, related tissue generated in the carcinoma, and that would increase the parathyroid hormone in the circulation. What would be the effects of primary hyperparathyroidism? There would be increased calcium and first of all there would be increased parathyroid hormone. This increased parathyroid would cause increased osteoclastic reabsorption of the bone, increased breaking down of the bone, and in severe hyperparathyroidism it would cause a condition that is known as osteitis fibrosa cystica, in which there are large punched out cystic areas in the bone which are filled with the osteoclasts which are breaking down the bone constantly. There would be multiple pathological fractures. What is a pathological fracture? It is a fracture in which there is no history of fall, no history of being hit with an object. The patient is just sitting, and when he'll try to stand, his bone may break down, or he's just lifting up a cup and his bone may break down. So these are pathological fractures. The second effect that would be of hyperparathyroidism, primary hyperparathyroidism, would be hypercalcemia. If there is increased calcium in the blood, it would cause depression of the central nervous system and the peripheral nervous system, muscle weakness, it would cause constipation, it would cause depressed relaxation of the heart during diastole, and it would also cause metastatic calcification, that is deposition of calcium in normal tissues. So calcium phosphate crystals would begin to deposit in the alveoli of the lungs, in the kidneys, the thyroid gland, and the walls and arteries throughout the body. This is metastatic calcification. On the other hand, if calcium is depositing in the already damaged tissue, that would be known as dystrophic calcification. Secondary hyperparathyroidism is when there is high level of parathyroid hormone occurring as a compensation for hypocalcemia rather than as primary abnormality of the parathyroid gland. So there is decreased calcium in the blood. That is why parathyroid hormone is being produced more and more from the parathyroid gland. There is no abnormality, no tumor in the parathyroid gland. A dietary deficiency of vitamin D would cause decreased calcium and increased parathyroid hormone. Poor absorption of fat, thus decreased absorption of fat soluble vitamin D would cause the same. Inability to synthesize 125 dihydroxy cholecalciferol, as in severe kidney disease and chronic kidney disease, would also cause hyperparathyroidism. And increased demand of calcium in the blood, as in the case of pregnancy or during lactation when there is production of milk. Calcium is a part of milk, an essential part. If the patient is not taking much calcium, then secondary hyperparathyroidism may occur. Secondary hyperparathyroidism would be characterized by increased plasma parathyroid hormone level, but decreased plasma calcium level and a decreased calcium excretion. In primary hyperparathyroidism, there would be increased plasma parathyroid hormone, increased plasma calcium, whereas in secondary hyperparathyroidism, there would be increased plasma parathyroid hormone but decreased plasma calcium. Okay, so remember this point. Now our next topic would be diabetes mellitus, that we'll discuss inshallah tomorrow. So see you guys then. Take care. Allah Hafiz.